Today, we are undertaking a deep dive into, well, one of the most widespread and complex neurodegenerative conditions out there, Parkinson's disease.
Hmm.
Our mission is to take that whole stack of sources you provided, the articles, the clinical notes, all that research, and really distill the crucial insights.
Right.
We want to understand that, that invisible chaos happening in the brain
Yeah.
that causes the very visible symptoms, and then explore the treatment landscape.
It's a fascinating journey into how we control movement.
Hmm.
At its most fundamental, Parkinson's disease, or PD, is a progressive degenerative neurologic disorder.
Okay.
And its physical manifestation is usually what defines it. It primarily affects the way the body moves.
And when you look at how it really impacts a patient's quality of life, their dependence, it boils down to four classic hallmarks.
That's right.
You've got the tremor, which often starts just on one side,
Mm.
then the muscle rigidity, that stiffness. You have bradykinesia, which is that just crushing slowness of movement.
Yes, all movement.
And finally, postural instability, which leads to those really debilitating balance problems. Okay, so let's unpack this. If those are the symptoms on the outside, we have to start inside the skull. What exactly is the core breakdown happening that, flips that switch?
Okay. Think of your brain as a really complex control room. Deep inside that room is a small cluster of cells called the substantia nigra.
Right.
This area is responsible for making dopamine, which is the chemical messenger you need for smooth, coordinated movement. The core problem in PD is the progressive loss of these dopaminergic neurons in the substantia nigra.
So they just die off.
They die off, and as they disappear, we see this massive reduction in striatal dopamine content.
Now, here's where I found the first surprising thing in the sources. We always think symptoms start right when something goes wrong, but the brain is, well, it's amazing at compensating, isn't it?
It is. It's incredible. What's fascinating here is that the PD symptoms, the motor issues you can actually see, they often don't become apparent until 60 to 80% of those dopamine-producing neurons are already gone.
60 to 80%. That's unbelievable.
The brain spends years trying to compensate for that huge deficit before the physical symptoms finally break through.
Wow.
And that chemical loss, it causes these abnormal nerve firing patterns that just impair movement. So if dopamine is the go signal, there's another neurotransmitter, acetylcholine, that acts as a kind of brake.
Okay, a balance.
Exactly. In PD, dopamine goes down, but the acetylcholine signaling goes up. It creates this imbalance where the movement signal is just stuck.
And if a pathologist were to look at the brain tissue itself, there's a specific calling card for the disease, right?
There is. They look for the presence of Lewy bodies. These are abnormal clumps of protein that build up inside the neurons.
And their presence is the hallmark.
It's the pathological hallmark of Parkinson's.
So moving from the what to the why, is this purely genetic? Is it something in the environment? What do we actually know about the risk factors?
The precise cause is, well, it's still largely unknown. It's almost certainly a mix of things. Some genetic susceptibility meeting an environmental factor.
So not one single cause.
No, and most cases are considered sporadic, meaning they just arise randomly without a clear hereditary link. But the risk factors are pretty well defined. Age is the big one. Risk goes up dramatically as you get older. Men are at a higher risk than women.
Interesting.
And on the environmental side, there are some correlations, though they're not fully understood, with living in a rural area or having certain occupations. And finally, if you have a first-line family member with PD, your own risk increases a little by about 2 to 3%.
That just paints a picture of this silent, gradual decline where the internal machinery is failing long before someone even notices they're struggling.
Exactly.
Let's talk about what that looks like on the outside. What does a patient first notice?
They notice the motor symptoms, and it's so important to stress this is usually a unilateral onset.
One say.
It starts on one side, say the left hand, and even as the disease progresses to both sides, that first side will almost always be the one with more prominent deficits. And let's get into those motor issues. The tremor is the most famous one. It often starts in the hands or feet, and crucially, it's most prominent when the patient is at rest.
So when they're not trying to do anything.
Right. When they go to pick up a cup, the tremor might get better, but when they relax, it comes back. Clinically, we look for that unique pill-rolling motion of the thumb and fingers.
It looks just like it sounds.
It looks exactly like someone is rolling a small pill.
That imagery is so clear.
Mm.
But the tremor isn't always the hardest part to live with, is it? It's often the rigidity.
The rigidity can be very difficult. It's this resistance to movement caused by involuntary muscle contractions. The muscles are just always tense.
And how do you test for that?
Well, if a clinician tries to move the patient's arm, they feel that stiffness. And the most specific sign is something we call cogwheel rigidity. Yes. When you move the arm at the elbow, it's not smooth. It catches in these short, jerky, ratcheting movements, almost like a clicking wrench.
And then there's the bradykinesia, the slowness.
And this is truly debilitating. It affects big voluntary movements and tiny automatic ones. It's why simple things, activities of daily living, become so hard.
Like buttoning a shirt.
Buttoning a shirt, cutting food, or you'll see someone's handwriting suddenly shrink. It also affects speech, leading to hypophonia, which is that soft, monotone voice.
It's like the loss of automaticity. You suddenly have to think about every single tiny action.
Precisely. And finally, you get postural instability, the stooped posture, the reduced ability to catch yourself. It leads to frequent, serious falls.
And there's a specific walk, isn't there?
There is. It's called festination. They take these short, shuffled, accelerating steps, and they often struggle with freezing, where their feet feel glued to the floor when they try to start walking or turn. They can also have retropulsion, a tendency to just fall backward without warning.
The motor symptoms are what people picture, but the non-motor issues are. Well, they're often the silent part of the disease that really crushes quality of life.
Oh, absolutely. They are pervasive. They affect sleep, mood, your mind. We see significant cognitive deficits, usually starting as slowed thinking and later progressing to memory loss and, in some cases, dementia.
And the emotional toll must be immense.
It is. Depression is incredibly common, often with fear, anxiety, panic attacks. And sleep is just completely disrupted. Insomnia, restless legs, daytime sleepiness, and something called parasomnias.
Which is what exactly?
It's acting out your dreams, really abnormal behaviors during sleep. And many of these symptoms can even show up before the motor problems begin.
That holistic view is so important. Now, before we get to treatment, let's clarify something, because the sources noted that not everyone with these symptoms actually has PD.
A critical distinction, yes.
Yeah.
Anyone who shows those classic motor signs, the tremor, the rigidity, the slowness, is said to have Parkinsonism.
But that's a broader category.
It's a syndrome, not a single disease. It can be caused by certain medications, head trauma, other neurodegenerative disorders. The key difference is this. If a patient has those symptoms, but their motor function does not respond to dopaminergic drugs, they're usually classified as having Parkinsonism from another cause, not true Parkinson's disease.
That really shows you how central that specific dopamine problem is to the diagnosis. So how do you identify it? Is there a definitive test, like a blood sample or a scan?
That's the tricky part. Because it's defined by the clinical presentation, there are no specific lab tests that can give you a yes or no answer.
So it's all based on observation.
Almost entirely. Diagnosis relies on the patient's medical history, a very thorough physical exam, and neurological tests.
So what are the MRI and CT scans for them?
We order those mainly to rule out other causes, things like a tumor or a stroke. In a true PD patient, those scans will almost always come back looking normal. Now, a neurologist might order a more specialized test, a dopamine transporter scan or DAT scan. It's a type of brain imaging that can show the loss of those neurons.
So it can see the root cause.
It can support the diagnosis, yes, but it's not a standalone diagnostic tool. It's used to confirm the clinical findings.
Okay, so since there's no cure, the goal of treatment is to optimize life. It's about reducing symptoms and keeping the patient functional. And the central player here is levodopa.
Levodopa is, without a doubt, the most effective drug we have. It crosses the blood-brain barrier, and the brain converts it directly into dopamine.
And it just works.
It works wonders for the tremor, the bradykinesia, the rigidity, but unfortunately, its effectiveness tends to diminish over time.
So if it's so effective, why not start it immediately? This brings up that central dilemma, right? The long-term side effects.
That is the genuine challenge. Physicians are often reluctant to start levodopa too early because the side effects become a major issue with long-term use.
What kind of side effects are we talking about?
The two big ones are dyskinesia, those uncontrolled, involuntary writhing movements, and the unpredictable on-off effect. Yes, it's where a patient can be moving fine 1 minute, they're on, and then suddenly the medication stops working and they freeze up, they're off. This can happen several times a day. Managing that is why doctors try to delay levodopa.
So you need other drugs to bridge that gap and to help levodopa work better later on.
Exactly. We use dopamine agonists. These are synthetic drugs that aren't dopamine, but they act like it. They stimulate the same receptors.
And you'd use those early on.
Often used alone early in the disease, or later they can be added to the levodopa to help smooth out those on-off periods.
And the other main group helps the dopamine you do have last longer.
Those are the dopamine modifiers, things like MAO-B inhibitors, which slow the breakdown of dopamine. But the really fascinating ones are the COMT inhibitors.
Okay.
Think of it like this. If levodopa is the fuel you're delivering to the brain, COMT is an enzyme that acts like a thief. It steals and breaks down the fuel before it gets there.
A fuel thief. I like that.
Right, so the COMT inhibitors, they act like a guard. When you take them with levodopa, they stop the breakdown, which means more fuel gets to the brain. And crucially, that decreases the duration of those terrible off periods.
And there are other more targeted drugs too.
Yes, older drugs like anticholinergics, mostly for younger patients with tremor, and amantadine for milder symptoms or to help with dyskinesia. And of course, we absolutely have to use medications for the non-motor symptoms. Antidepressants, anxiolytics, sleep aids are all essential.
It's clearly a multi-layered chemical juggling act. But it's not just about chemistry. Let's shift to non-pharmacologic options.
Non-pharmacologic therapy isn't just a supplement. It's an essential part of the care. It's crucial for prolonging that mild stage of the disease and delaying disability.
It's a team effort.
A huge team effort. Neurologists, nurses, physical therapists, occupational therapists, speech therapists, all working together.
And if there's one simple, single intervention that makes the biggest difference, the source material is crystal clear. It's exercise.
It is paramount. And we're not just talking about a simple walk. This includes strength training, Tai Chi, yoga, Alexander techniques.
All aimed at fighting back against what the disease takes away.
Exactly. Improving flexibility, balance, muscle strength, and posture. All the things PD actively degrades.
And for advanced disease, when the medications aren't working as well, there are surgical options.
Yes, for advanced disease. The most common is deep brain stimulation, or DBS.
How does that work?
DBS involves implanting electrodes into specific parts of the brain. They're linked to a neurostimulator that sends targeted electrical signals.
And the benefit?
It can be dramatic. It may significantly decrease the amount of levodopa a patient needs, which helps stabilize their symptoms. But it's a major intervention. It requires frequent follow-ups for adjustments.
And there are serious risks, I assume.
Of course, like any brain surgery, there are risks of hemorrhage, infection, stroke, and even device failure.
Before we wrap up, we should touch on early onset PDSO, onset before age 50. Is the disease different for these younger patients?
It is. They often face a slower overall disease progression, which is good, and a lower rate of dementia. But they have unique challenges. They're more likely to have dystonia, those sustained muscle contractions, right at the onset.
And they'll be on the LOPA for much longer.
For decades, which means they're much more prone to developing those severe levodopa-induced dyskinesias we talked about. And for women in this group who want to have children, the sources really stress getting a geneticist referral and having a thorough discussion about medications.
And finally, let's circle back to prevention. I mean, is there anything we can do?
We don't have a definitive roadmap, no. But the research points to some really tantalizing things. We know exercise is therapeutic, but studies also suggest it may actually reduce the risk of getting PD in the first place.
And there were two other things mentioned.
Yes. The consumption of caffeine and regular intake of green tea. Both have been associated with a decreased incidence of the disease.
So what does this all mean? Parkinson's is defined by this deep chemical failure, that 60 to 80% loss of dopamine neurons. And it demands these incredibly complex, tailored medical interventions. Yet, alongside these advanced treatments, you have these simple lifestyle factors, exercise, caffeine, green tea, that are accessible to almost everyone, and they show these concrete hints of being protective.
It's a fascinating contrast.
It really is. So based on everything we've unpacked, consider this. What does the power of these simple interventions suggest about the future of neuroprotection research? Is the next major breakthrough waiting not in the lab, but maybe in optimizing these common daily behaviors? We'll leave you with that thought. Thank you for diving deep with us.